My name's Elise Summers. I'm one of the PA students. I'm going to be doing an abdominal exam on you today. Is that okay?
Mm-hmm.
Or do you have pain anywhere?
No.
Okay, perfect. So if she did have pain, you want to start the furthest quadrant from it and then do the painful quadrant last for percussion and palpation. Okay. All right, I'm going to go ahead and lay you back. I'm going to put this up just a little bit. So if she was in pain, you could put this up a little bit and then have her bend her knees, and that relaxes the abdominal muscles as best as they can.
Do you want me to say I'm in pain?
No.
Okay.
No. And then that way, she's not going to be pain-free doing that, but she'll be sort of as relaxed as she can. So that's making the patient comfortable and sort of the correct positioning for the abdominal exam. Then you need to see everything. So can you bring your shirt just up to here and pull the shorts down below? There you go. Perfect. So the first thing we're going to do is we're going to just look. Have you relax these down at your side. Good. And so I'm looking at the contour, which is flat. I'm looking for scarring. There doesn't seem to be any scars. Some patients will say they haven't had surgery, and then you look at their belly and there's a scar. And so then you're asked about it. You're looking for pulsations. You can see, if you look closely, that you can see the pulsation of her aorta, which is normal in thin, young people, both males and females. You're looking for vascular changes and striae, so stretch marks. So those are the things that you're looking for. Then what do we do next?
Awesome.
Listen. So listen in 3 different areas in each of the quadrants. And you're just sort of lightly pushing. You're not even really pushing. You're just laying the stethoscope on. If you push, it's almost like you're doing palpations. You don't really want to push very hard at all. And I'm moving once I've heard a couple of bowel sounds. And if I don't, then I wait almost a full minute to make sure that there aren't any before you actually say it's hypoactive. So as long as you hear it, you can move it relatively quickly, but you do want to listen until you hear something, and if you don't, you need to wait like a full minute in each spot. Yeah.
Yesterday it was like, I think it was like between like 5 and 30 was normal, like with the vowel sounds. Do you want to wait till you hear 5?
Mm-hmm. Okay. Yeah. So once you've done that, then you listen over a couple other spots. So then you listen over the liver for a friction rub, and that's just it's gonna sound almost like scratching, like something is rubbing on the lining of the rib cage. Then you listen over the spleen, which is going to be over in the last ribs. And again, normal is you should hear nothing. Then you want to listen over the aorta. This you're listening for a bruit. Then the renal, if you think about where are the kidneys. Iliac. And then femoral. So for the competency, put these where they're supposed to be, and the femoral you can just go over their pants because it's kind of low in the pelvic region. So that's auscultation. First bowel sounds, then friction rub over the 2 organs, then the vasculature. Okay. Then percussion. So this is the thing that you'll have to practice, and you can practice on different sort of parts. You use and you lay this finger, your middle finger of your non-dominant hand, where you're trying to percuss. And then it's a wrist motion. So it's not the finger, it's the whole wrist is almost like a reflex hammer. And so I'm just kind of listening. You probably can hear it the best. That it's overall sounds like it's airy inside. And again, you're in general doing 3 areas in each quadrant to do that. So you want percuss each, is it overall resonant over the abdomen? And then you're gonna percuss for the size of things. So to percuss the liver edge, you're gonna start at or below the umbilicus, because in general, the liver's not gonna be enlarged enough that it's way down here. So you wanna be out of the way of the liver. You're gonna be in the mid-clavicular line, so down here. Did you hear that change?
Yeah.
So the change happens, it's tympanic there, in about her first rib space is dull. So you would mark there. Then I'm gonna try and get up between these ribs. So it's airy there, so her lung tissue is here, and then I'm trying to get between the ribs when it's dull again. And it happens in this rib space, so between here and here. And if you measure that, that's gonna be between 6 and 12 centimeters. Okay, so mid-clavicular line, start down below, percuss up, should be airy until it's dull, and it should be either below the first rib or right in that first rib space. And then the same thing, start nipple line and move down. It should be airy because it's lung, and then dull again as you hit the liver. Then the spleen, you're gonna kind of follow the contour of this last rib. And let me actually read what it says. Okay, so it says start at the anterior axillary line at the level of the 6th rib, xiphoid process, percuss toward the mid-axillary line. Should hear, it should be H-E-A-R, tympany. And you should hear tympany because there is no spleen there. So if it's enlarged, you hear dull because the spleen that sits down here is now kind of wrapped up and come anterior and down toward the umbilicus. So you're gonna kind of start up here, and again, it should be tympanic. And again, it is all the way until sort of all the way down here, which is normal. Okay? So that's percussion. Then palpation, again, you'd start in the quadrant furthest from the pain. If they're not having any pain, do whatever you sort of always do. I always start in the right upper quadrant and move around from there. So kind of you set what's normal for you and do that every single time. So you want to start with light palpation, and you want to be looking at the patient's face. And then that way, if they have pain, you know, you are able to tell how much pain they are in. Because some patients will be like, oh, it's just a little bit. Yet they're like, I'm like gripping the table. So that's light palpation. Then deep palpation, you're trying to actually feel sort of below the skin and the subcutaneous tissue, and you're trying to feel organs. So if you think about how far and how deep the organs are, you got to push pretty hard. So again, 3 places, light and then deep all the way around. Then you feel specifically for different organs. So if you start with the liver, you kind of roll your fingers up like this. And you're feeling toward the liver. And if you don't feel the liver, if you have them kind of take a deep breath in and then breathe out, sometimes you can feel the edge of the liver kind of bump into your fingers. And if you don't feel anything, it's all right. The spleen, same sort of motion. You're kind of just moving your hand over like this to feel the spleen. And again, it should be tucked under those ribs. You shouldn't feel it. The rigidity and guarding, just make a statement as you're feeling this, that the abdomen is soft. You know, if she was in pain and either voluntary guarding or involuntary rigid, her abdomen would be rock hard, you know, because one, for the voluntary, she doesn't want you to touch it because it hurts, and the involuntary, it hurts. So she's rock hard in the abs. Then kidneys, so one hand underneath, one hand on top, and you're trying to squeeze the kidney and kind of feel, and then as you kind of slide your hands off, you should be able to kind of feel the kidney pop in and pop out. Again, it's kind of like an ovary. You may not actually feel it. It's okay if you don't. If it was enlarged, you would see it. So from this side, if you reach under here, so again, pull towards you, and then push down like this. If you don't feel like you can do that, or you can't get over the patient, you're too short, the patient's too big, you can go around to the other side. Uterine height, again, you're just feeling sort of like you did in the bimanual, except just on the outside. Do you feel anything? You shouldn't feel anything outside of the pelvis. Again, bladder should be super down low. In order for it to be outside of the pelvis, or for you to be able to sort of feel it, needs to be really full. So like 600 mLs. Then the measure of the aorta. So the pulsation is in here. And you want to do the best that you can to get on either side of the pulsation. You can kind of see that maybe it's accentuated as I push down. Can you feel that I'm on top of the aorta? Yeah. So then you want to get pulsation on either side of these, and then you measure in between and kind of squeeze in until you just feel it on your fingers, and measure the space in between. Okay. So that is sort of the typical exam. The aorta you don't even do on all patients. Do it on the practical, but it's generally going to be people who are at risk for an aneurysm, or over the age of 50. So then the special tests, ascites. So the percuss for mapping dullness. We have the figure written there in case you forget, but that's generally like you want to actually going to write sort of or draw a line on the patient. So you'd start at the middle, you percuss out until she's dull. She doesn't get dull until around the edge. So on you guys, it will likely, you won't have any dullness up here. So she's tympanic all over here. So the dullness line is going to be like this. So that's mapping dullness. If she had ascites, it would be much smaller. Then you do the next test for shifting dullness. So she rolls up, roll that way so that we can see you on the camera. But you can do either one. So then behind the patient, you do the same thing. Percuss. And she's still tympanic all down in here. So it doesn't change, the dullness doesn't shift. So if it was ascites, gravity would pull it down, and the sort of new fluid line would be down here. You can roll back. Then the fluid wave, I'm gonna move your hand. So if you put your hand on your belly like that, so ask them to help you, kind of put it there, and then you want one hand on one side and one on the other. And so you are pushing sort of, on one side like that, and you are trying to feel fluid waves. So you're actually trying to feel the vibration through the abdomen. It's going to travel through fluid, but it won't necessarily travel through the intestinal tissue, and just if there's no fluid there. So you shouldn't feel anything, okay? All right. Then rebound tenderness. So if you push in and let go, the patient will be more sore on the let go than they are on sort of the pushing. Then McBurney's point. So you're going to sort of draw this kind of angle from the ASIS to the umbilicus, and the appendix is going to be about 2/3 from the umbilicus to the ASIS. And so it's simply just pushing in that spot. So that's McBurney's point tenderness. Rovsing is you push on the left side and they get pain on the right side, so over the appendix. Then you have the psoas and obturator. So if you can pull your knee towards your nose. So we're gonna do that. And then if you pull this up, bend your knee, and then I internally and externally rotate. So if any of those cause pain, that's sort of a positive sign for peritonitis associated with appendicitis. Murphy's sign is going to be for acute cholecystitis, right upper quadrant. You're going to push sort of up under the ribs. You have the patient take a deep breath, and then you push more. And if they stop or they say more pain, depending on where you look and who's sort of telling you what Murphy's sign is, that would be a positive sign, and it's for acute cholecystitis. Questions about those before I sit her up? No? Okay, the last thing is, if you can sit, I can help you up if you need to, is CVA tenderness. So you sort of find the last rib, the spine, hand here, and it's sort of a pounding on the back. So find the last rib where it meets the spine. That's the costrovertebral angle. If you can't see, you can come around. So it's right here.